So I'm going to try in 30 to 40 minutes to go through some of the concerns of the National HIV Program and have a look at some of the guidelines put out by the National HIV Program. First off, in terms of background, and this is stuff I'm sure you've heard many, many times before, the previous census, the last one hasn't been published as yet, indicated there are about 2.75 million of us, and it's estimated that out of that some 32,000 persons are living with HIV. It's estimated from that again that some 14,000 require antiretroviral therapy. But the numbers that the program has counted so far of persons on antiretroviral therapy up to the end of 2011 was just some 9,162 persons. This means that we only have 58% of those eligible actually receiving antiretroviral therapy. We are significantly increasing testing, and so yearly we're doing over 250,000 tests now. But as you shall see, that's not quite enough. The characteristics of the epidemic has changed somewhat in Jamaica. It certainly was a generalized epidemic, but we're starting to see features now of a concentrated epidemic. We're finding that in terms of antenatal clinic attendees used as a proxy for the whole population, the prevalence is reducing. A lot of work has been done with female sex workers, and they've been very good at condom use, and so the prevalence there is also on the downward trend. STI clinic attendees too, there is some movement there. But in terms of the most at-risk populations, in terms of certain concentrated groups, like men who have sex with men, the prevalence is stuck at 32%. It hasn't really moved from that over several years. In terms of cocaine and crack users, drug abusers, it's estimated at about 5%, and homeless persons a very high 12%. So we do have features of a concentrated epidemic. This is what we're all working for, and it's one of the reasons I think that some of us love HIV medicine. It's cutting edge, and we get to see significant results fairly quickly. So this is the same Haitian patient on the right, being after he had received and had taken properly his antiretroviral therapy. Notice that he now has children, so he is having unprotected sex. The objectives of the program are quite clear: to promote early and greater engagement in care, that is to get persons into the clinic and to retain them, to ensure effective, durable viral control, leading to improved health status, a near normal life expectancy, and an enhanced quality of life. In other words, HIV being a chronic disease and afforded chronic care, and prevention is an important part of the management of the disease. As I said before, we're having some success. The prevalence at antenatal sites is reducing and does continue, the trend continues. We're seeing a 25% reduction in AIDS cases over the years, and a significant 40% reduction in mortality due to HIV. So we are having success. However, it continues to be a significant problem, and a problem especially amongst the young. Amongst the 15 to 49% age group, it's the leading cause of death, and the greatest number of persons suffering from HIV are the young, productive persons in our country. So the challenges are many, and I've listed some of them here for us to have a look at. The biggest one being sustainability, and we'll go down this list as much as is possible. So sustainability perhaps dwarfs everything else at this time, in that, as a famous person once said, you require cash to care. This is the HIV/AIDS expenditure. So this is the total expenditure in Jamaican dollars, $1.odd billion. Of that, only 26.2% is out of the public purse, and some 73% comes from external donors at present. Now that always puts you into a problem. In terms of our donors, the Global Fund is the largest external source, then the World Bank and the government of Jamaica. there are many other persons or many other organizations that contribute to our cash to care. I'm sorry for this jumbled slide, but note here, this is treatment, care, and support, a breakdown. In terms of antiretroviral therapy, this is what we require, some 230 odd million Jamaican dollars. Outpatient care, which is largely covered by the government in terms of staff costs and lab costs, another $33 million. So we require, at the very least, 200, almost 300 million Jamaican dollars. Because at the end of 2013, the global funding program, the Global Fund program comes to an end. They, after that, will contribute only to specific targeted interventions and not, as they are doing now, give us a sum of money that we're able to use to purchase our antiretrovirals. The government of Jamaica, though, has committed to undertake this through the National Health Fund. And so antiretroviral care, free of cost to the patient, will continue into 2014 and beyond, as long as we pay our taxes. Yeah. In terms of treatment, this is where the money goes. As I said, antiretroviral takes up the largest portion. And the Global Fund contributes in no small measure to that. So come the end of 2013, there's going to be a significant hole. But the government has undertaken to take that up and will put it on the budget to the Ministry of Health. So sustainability is at least partially covered, but there are many other facets to that, which of course time doesn't permit me to go into, and perhaps we can discuss. But there are also a high proportion of persons living with HIV who simply don't know their status. And so we have to get those persons tested. Some 15,000 persons roughly are thought to be infected and are not aware of their status. It's mostly males and younger peer persons. They're less likely to be tested. And we're still testing only about 10 to 20% of hospital admissions. We have to increase our testing of persons. Persons have to be aware of their status. If they're not aware of their status, then that's where things end. And this is just to indicate that there are a number of missed opportunities for HIV testing. In this particular study from 2007, some 73% of persons did have at least one healthcare visit prior to their diagnosis. Only 20% had a diagnosis which would initially make us think of HIV/AIDS. So 80% of them presented with symptoms and signs that would not initially cause us to think of HIV/AIDS as a diagnosis. But 42% of them developed AIDS, end-stage disease, within a year of their diagnosis. And that's more typical of men. So we have to start testing. We have to test generally, routinely, and often. And so the HIV program has decided on opt-out testing and screening in all healthcare settings. Right now it's being pushed particularly for hospital admissions and A&E departments. But we have to move further to all healthcare settings that persons are offered opt-out care, meaning that it is routinely done unless the patient asks that the HIV test not be done. And this is where all of us as private practitioners have to come in. So it should be all persons tested. It should be persons at high risk screened at least annually. Separate written consent for the HIV testing is not required. It should be a part of the testing that we offer just to make a diagnosis, as we do with any other test. We really should be telling the patient what we're testing them for and why with any blood test, with any intervention like that. And HIV testing should become a part of that. The pre-test counseling is going to be de-emphasized in that there doesn't have to be formal pre-test counseling for the patient before the testing is done. But post-test counseling must be done and continues to be extremely important. So we need a partnership with private practitioners to start testing and start testing routinely as you would any other test. Persons who do know their status though are still not accessing treatment, or they access at a late stage of the disease. So so right now, the ARV coverage is only 58%. In years to come, we have to increase that. We want to cover at least 90% by 2017, which means we're going to have to nearly double the amount of persons on antiretroviral therapy. We're going to have to double the cost for antiretroviral therapy. And we're going to have to incorporate all healthcare settings in treating this chronic disease. And the reason we want persons to access care and to access it early is quite clearly shown by this. Persons who are diagnosed late, the mortality is significantly greater, especially in the older population, versus those who are diagnosed early. Additionally, there's a much greater cost associated with patients who present late versus patients who present early. So the cost would be less if we can bring in more persons and put them on care early. Is that for me? Poor adherence continues to be a significant challenge in that patients in the clinic on antiretroviral therapy are not adhering to this therapy. And I think as practitioners, we can all empathize with that, in that taking any chronic medication over a long term is very, very difficult, especially when this is something you're going to be on for life. But we're all aware of this study, which indicated that we require some 95% adherence in order for the medication to work. What is it that we're having in actuality? Well, when we measured adherence over the past years, this one being 2011, we're still running at about 80%. And that's with our best efforts. And that's with pill counts, which are notoriously unreliable. So it's probably even worse than that. So we're not getting the adherence that we need. So at every intervention, at every meeting, adherence has to be stressed over and over with these patients. In order to assist with adherence, the pill burden is being reduced, so that now we have fixed dose combinations, which are reducing the pills even less and less. And we've recently introduced an A-triplet generic, which contains tenofovir, emtricitabine, and ephedrine in a fixed dose combination. So it's one pill daily, just one pill a day. Still a problem with adherence. Then there's a need to increase. So even the persons who want to take their pills have a difficulty, because where can they get the antiretrovirals that's convenient, that's safe, that's confidential? We need to increase access. We need to be able to forecast properly so we don't have stockouts. And that's a difficulty because we're not getting the pharmacy reports. We're not getting the reports as to the actual and the real numbers of persons on antiretroviral therapy. We need you to help us with reporting these so that we can buy the drugs, we can order, we can forecast, we can put the funding in place. We need updated guidelines, and there has been work in that there are updated treatment guidelines, and there are some other guidelines that we should look at briefly. But we need increased access also to private pharmacies. And there has been some move on that. We had some 4 pharmacies that have a memorandum of understanding with the National HIV Program. That has been increased now to 6. And they're spread Kingston, Mandeville, Portmore, Spanish Town. But we need to move it further. We need pharmacies in the West, for example. And we continue to